We wanted to tell you more about the health situation in northern part of Ethiopia. As you have seen from our media advisory, we have two speakers today with us. Mr. Altaf Musani, who is our Director of Health Emergency Interventions, and Dr. Ilham Noor, Team Lead for Ethiopia. She is also Incident Management System and Emergency Operations member of that department. So before I give the floor to our speakers to make their opening remarks, we will send you those remarks during this briefing or just at the end of it. So you will have it, and there is no embargo to that document or to what is being said today. So with this, I'll give the floor first to Mr. Musani, and then Dr. Noor will complement. Mr. Musani.
Tariq, thank you very much, and good morning, good afternoon, and good evening to many of you. Let me start with the fact that you cited that there are a number of emergencies and humanitarian events that we continue to track. The recent humanitarian update put out by the Office for the Coordination of Humanitarian Affairs reflects more than 300 million people in need, particularly in 63 countries. The overall appealing amount for the humanitarian agencies and partners to help them is more than $50 billion. This reflects an update from Ukraine, the floods in Pakistan, as well as food insecurity and fuel shocks and potential famine throughout the world. In particular, in Ethiopia, more than 20 million people throughout the country are in desperate need for humanitarian and health care. 3/4 of them are women and girls. And I'm reminded every day that behind these numbers are women, are children, are boys, and are elderly. The World Health Organization continues to monitor health risks, as well as aims to mitigate and contain them when access is facilitated. As a result, what we've witnessed in Ethiopia are confirmed outbreaks. WHO is confirming an outbreak of cholera ongoing in 3 sub-districts in Oromia region and 1 neighboring district in the Somali region. A total of 273 confirmed cases have been reported. In addition to cholera, we're deeply concerned about the measles situation. As of the reporting week 41 of the calendar year, we've already confirmed more than 6,000 confirmed measles cases that have been nationally reported. 86% of these cases come from drought-affected districts. And currently 13 waridas have active measles outbreaks. In addition to infectious diseases, we are deeply concerned about the malnutrition situation in Ethiopia. According to the World Food Programme, the rate of global acute malnutrition among children under 5, particularly in Tigray, is 29%. This means almost 1 in every 3 children under 5 in Tigray is malnourished. Severe acute malnutrition among children in the region is 6%. 65% of children have not received nutritional support in over a year. We're very clear about the cycle of malnutrition and disease and the likelihood for death. I'd like to hand over to Ilham, who will give us a deeper dive into the situation into the north.
Thank you, Altaf, and good morning, everyone. Just a focus on the health situation in northern Ethiopia. We have about 13 million people who are in need of food and humanitarian assistance in Tigray, in Afar, and in Amhara. We have access in Amhara and Afar, so we know more about the situation there, and we are able to intervene and support. However, we do not have access in Tigray. There was no air or road access in Tigray for the last 6 weeks. Before that, the access was intermittent between March and August this year. And during the humanitarian truce, we were able to bring in some supplies. Not a lot, but small quantity that covers really a small amount of the needs there. We were also able to support some health services in Tigray, support the measles campaign there, but we were unable to distribute supplies very quickly because of little cash and fuel. We were unable to undertake malaria prevention activities because of the same reasons. We were not able to extend the COVID-19 vaccination campaign beyond the capital, Mekelle. So we have a huge issue of access there. There are 5.2 million people in need of humanitarian assistance in Tigray, and that number includes 3.8 million people who are in need of health assistance. And we need to reach these people. We need to reach them because we need to prevent avoidable death and suffering. We need to prevent disease outbreaks, because in this situation, the risk of outbreaks is high. The conflict is also causing displacement in Tigray, in Afar, and in Amhara, and we need to reach these people because displaced people have certain vulnerabilities because of displacement. We are beyond access. We are also concerned about health issues, the major health issues, malaria, for example. We're also concerned about acute malnutrition in the 3 regions, as just my colleague has mentioned. I'm also concerned about trauma care, about access to antenatal care, delivery and perinatal care, immunization, and so on. So I will just give a few examples of the situation in this regarding these major health issues. Not everything we know, because some areas, for example, in Tigray, we do not have reporting. Only about 30% of health facilities in average report weekly to the information system. That's mainly because there is no telecommunication and there is little fuel, so the reports have to be handed physically to the system. But we have an increase in malaria cases, and we're concerned about that. Malaria cases in Tigray and in Amhara regions. Currently, we have 80% increase in Tigray, 40% increase in Amhara compared to the same period last year. Fortunately, the cases in Afar are decreasing of malaria. So we need to implement and undertake activities to prevent and treat malaria. This is a malaria transmission season. In Tigray, malaria outbreaks are already being reported, but we cannot access those areas. And the malaria areas are also where we have high number of internally displaced people. And as I mentioned just a few seconds ago, these are vulnerable people with special needs. We are also very concerned about food insecurity and acute malnutrition. In Amhara and Afar, especially among internally displaced children, we have high level of acute malnutrition, about 19% in Amhara and 40% in Afar. Again, as I said, among internally displaced children who are under 5 years of age. But in Tigray and according to WFP, there is a staggering level of food insecurity. 89% of the population are food insecure, and 47%, that's almost half, are severely food insecure. My colleague Altaf just mentioned the statistics on the acute malnutrition among children in Tigray and among also pregnant and breastfeeding women. And if I can cite also, according to WFP, half of these women, 55%, are acutely malnourished. And on that number, below 50%, less than half of them are enrolled in treatment program, again, according to WFP. So we're really gravely concerned with these statistics because malnourished children are usually very sick. They need urgent treatment. Some of them will need hospitalization and around-the-clock care. When they get sick, they tend to get a severe disease. They tend to die as well. That's also for pregnant women and breastfeeding women. It makes them vulnerable. They have already a biological vulnerability because of a pregnancy, but then the malnutrition makes them even more vulnerable. And obviously, we need to intervene urgently to prevent unavoidable death and suffering. As I mentioned as well, we are also concerned about the high risk of disease outbreak, also availability of immunization services. For the in Tigray, for example, routine immunization in children have fallen below 10% this year. This is a region where we usually see high level of coverage pre-conflict, more than 90%. So this is we have a high risk of diseases that can easily be prevented by vaccines that are available, that they can get spread. In Amhara, we have about 1,141 measles cases this year, but fortunately we were able to support a reactive measles vaccination campaign. And there is also a national measles immunization campaign that is going to take place nationally. So we are happy that we are able to intervene where we can and where we have information and where we have access. So I'll just be finishing my remarks by saying that it's important for us, these issues of access, issues of people being underserved because we cannot access them or because the health system is not able to serve them, which is something really we're gravely concerned about. Thank you very much. Over to you, Aldo.
Thank you, Dr. Noor, and thank you, Mr. Musani. We will now open the floor for questions. And we'll start with Antonio Brotter from EFE News Agency. Antonio, please.
Thank you, Tariq. Good morning. I would like to know how many cases of malaria have you registered, and if you have even incomplete data on cases of measles and cholera in Tigray. Thank you.
Yes.
Thank you for the question. Yes, we do have weekly cases of malaria in Tigray. That's, I presume, the questions. I don't have the exact number right now in front of me, but definitely I will share that with you. But regarding cholera and measles, we don't have currently cholera cases in Tigray. Measles, we do receive sometimes alerts of possible or suspected measles campaigns, but it's very hard to investigate because, as I said, there is issue of fuels, there is issue also of telecommunication to get the information, even taking, because if you have cases, you will need to take samples, you will need to transport them to Addis for testing. So this is not easy because of access issues, and also, as I said, a small number of health facilities report. So we don't know the full picture, but from what we know, we don't have currently cases of measles and cholera in Tigray, but the risk is definitely high.
So just to underscore that point, when we track information, it's vital that the routine systems that were established function. clearly in parts where we have very little information or access, those systems don't work because there's no fuel, there's no incentives, and there's very limited transport in order for us to be able to move that information across. So the measles cases that I cited are nationally cited. That's what comes from the routine system. The cholera cases are in the drought-affected areas. And what we do know when systems do work is there's been, at least in the case in point of malaria, at least a 33% rise from one year to the next. So these are factors that we continue to follow. Information comes in not in a consistent manner, but this is why information such that we get from health facilities, from health care workers, is vital for us to be able to get an understanding of what's happening with the situation. But we've defined the risk very clearly. We've talked about the risks to populations when there is no food, there is no fuel, there is no electricity, and when there's limited access to healthcare, it is more than the perfect storm. And hence the appeal for access and sustained resources to be able to contain some of those problems cited earlier.
Thank you both. Let's go to the next question. Agnes Pedrero from Agence France Presse. Agnes?
Yes, hello, good morning, everybody. This morning you have presented us lots of statistics on different diseases. But what I would like to know is how you evaluate the health situation in general and what is your main concern today? Because you talked about cholera, malaria, measles. What is your main concern? Thank you.
So it's a very important question, and it has probably a multiple set of answers, but let me try and be brief. The basis of how we define a health situation is the health risk assessment that we piece together through routine information that we've had throughout the weeks and years that we work in Ethiopia. There's a set of infectious diseases that we're deeply concerned about. Ilham has cited some of those: cholera, measles, malaria, diphtheria, meningitis. The list is endless. Those diseases, of which are endemic in country, and particularly what we're not having access to in the north, are what we're citing in terms of risk for outbreaks. And there are a few outbreaks outside of the north, which I've shared with you. In addition to the burden of infectious diseases and outbreaks, malnutrition is a deep concern. I think, again, Ilham cited the plethora of statistics that we have, whether we use the global acute malnutrition rate. Particularly worrying for us is severe acute malnutrition and those children who do get admitted for medical complications that are severely acutely malnourished. And then, of course, it goes without saying that there are chronic conditions throughout Ethiopia, and in particular in the north, that we're equally concerned about, which people need access to the system. And when Ilham described the system is either non-functional or under utmost stress because the lack of fuel to run operating theaters, the lack of medicines to be able to do treatment, as well as to be able to perform the necessary diagnostic materials. So when you look at the range of health risks, it's large, it's immediate, it's real, and our challenge as not only the World Health Organization, but healthcare providers is to be able to meet the totality of health needs and health risks. But again, stressing on the outbreaks, as well as malnutrition, and those who need access to healthcare, including women who must deliver in safe spaces.
Thank you very much. And we will be sending shortly the remarks that have been made, so you will have all those numbers with you. And now we go to Lisa Schlein from Voice of America. Lisa?
Yes, good morning, Tarek, and good morning to the panel. I'd like to know, since from what I get from what you say, then at the moment cholera and measles are not present in Tigray. This is not your concern there. So what diseases are of main concern to you? Malaria, COVID? I mean, if you could elaborate upon that. And do you have any information about deaths which have resulted from disease, but also from the relationship to malnutrition, serious malnutrition, lack of food, and so forth? And then peace talks presumably have begun between the government and the Tigrayan rebels, and I think the AU is mediating and so forth. Do you have a place at the table? Is your message, are the needs
that WHO has in terms of access to the area, getting through in any way? I mean, this seems, I guess you still have people that are working there. Is that right? That they're working under great hardship without the kind of material that is needed. Thank you.
Thanks, Lisa. I think we can see we can clarify this thing on cholera and measles. I think it's of concern like all the other diseases. We are part of a larger UN humanitarian community, and we are advocating, as Altaf has said, for greater access on all levels. Our really focus is on trying to get health assistance to health workers so they can serve the population. But maybe more on cholera and measles, because I don't think that we can say that it's not of a concern.
Absolutely, it is of concern to us, and that's what I have mentioned earlier. It's just that we don't have much of information, and that when we don't have information, we're even more concerned than when we do have the information, because it's harder to act. So measles and cholera in Tigray are a concern, but what I said that so far we haven't, from what we know, we haven't recorded or cases haven't been reported or confirmed yet. Definitely, in terms of the health issues, I have mentioned them. Malaria for us is a big concern. Diseases that can be easily prevented by vaccines, by cheap available vaccines, is of big concerns to us. COVID-19, obviously, access of women and children to delivery care, to antenatal care, to skilled birth attendants. All these are concerned for us, and from the small amount and limited amount of data that we have, the utilization of these services have gone really, really down. I have mentioned the statistics about the immunization, but also we know that between 2019 and 2022, antenatal care visits utilization has dropped by 60%. By 70%. Skilled birth attendants by 60%, 70% and 60%. So these are concerning to us. In terms, just one last thing that I would like to touch upon, which is the data on mortality, especially among malnourished children. We don't have a full picture of that, as I said, because few health facilities report, and also most of the time these deaths happen in the community, and there is not effective ways of actually knowing, whether because there is no telecommunication or because they cannot actually transport these very sick and dying kids to where they can be registered. Thanks.
Thanks, Ilham. And let me just stress, when we talk about vaccine preventable illnesses, the vital vaccines that we've been talking about for many months and years, immunization services in Tigray have stopped. Ilham mentioned very clearly what the current coverage rates are. So that is deeply worrying and alarming, that when we have vaccine preventable illnesses, when we have the solutions, we're not able to get those jabs in the arms of children. And there's a whole range of issues associated with the availability of vaccine, fuel, and funding in order to get vaccinators out to hard-reach areas. In addition to that, as Ilham mentioned, for us to be able to clearly have a perspective on the situation, we need information systems to be turned on. Information systems are dependent on fuel, funding, and transport. We cannot access information without those parameters in place. And of course, we often know, based on past experience and studies around the world, that in these situations of hardship and limited access, that often death happens in the community level that goes underreported and unregistered. But we want to stress that that in Tigray and in parts surrounding, and we've learned this from COVID, diseases do not know borders. They do not respect those borders. So whether it's measles, malaria, or suspect cases of anthrax, these things will move. And hence, our ability as a system at large to detect and contain them is vital. And in the case of northern Ethiopia, those systems are either stretched or non-existent.
Thanks. Maybe also just on a question of being on the ground, that we can confirm that we do have a presence on the ground, but with this limited access and shortages, it's very difficult for our colleagues to provide assistance. Imogen?
It strikes me from what you're saying that in Tigray you really have so little access and negligent communication that actually you really don't know what's going on, but what you fear is pretty catastrophic. And we did hear your Director General last week say that there was a very small window of opportunity to prevent genocide. Is that an assessment? I mean, that's a big word. Is that an assessment you would share?
Thanks, Imogen. I think we have a responsibility to speak about the suffering of populations in all emergencies. This is what we are trying to do every time we come to speak to you about all the emergencies that we are trying to address. And this is why Dr. Tedros every week is speaking about needs of populations in different parts of the world. But let me ask Altaf and Ilhan on how much we fear what we don't know.
And I think it's not a question that over the last 2 years we've had no access. And when we define access, there's a whole range of issues to be able to say, are we getting medicines routinely into health facilities and out of warehouses? Are we able to get vaccinators out of health posts into hard-to-reach areas? Our teams are on the ground. We have health actors and health cluster partners who are actively on the ground. And of course, there's the workforce. So a lot of our information is either based off what we define as the risks that I mentioned. We carve out very clearly what are the threats to health and survival in the north. And then we work with the partners to make sure that are we seeing what we are worried about. And as I mentioned very clearly, immunization service is a lifeline to children to keep them alive. Those services have stopped. We know there are confirmed reports of stockouts, IV fluids, antibiotics, other treatment medicines don't exist in those facilities. We have firsthand recorded that information. And that's when we start piecing the picture together against what we define the risk, we are deeply concerned. And therefore appealing for opening up that access, making sure it's sustained, and making sure that we address some of the other variables or elements to ensure that we're able to vaccinate children, make sure that hospitals can do surgeries, and make sure that children can get admitted to therapeutic feeding centers. And that is vital to be able to avert unnecessary death.
Thank you, Mr. Musani. And now we will go to Laurent Sierro from Swiss News Agency. Laurent, that will be probably the last question, as we are already at 10 o'clock. Laurent?
Yeah, thank you, Tariq, for taking my question. Actually, some of my questions were already answered, but maybe on the DG, the fact that he's from Tigray and that is so vocal and so regularly, does that make the discussions on the ground with the authorities to try to unlock the situation more difficult? What do your people on the ground say about that? Thank you.
Hi, Laura. I think this is really something that we have been trying to work with on the issue of the access with other agencies, and maybe our colleagues from OCHA may speak more about overall access issue. When it comes to Dr. Tedros, he was openly speaking about situation in Tigray in a number of press conferences as he was speaking about other health emergencies around the world. It's part of our mandate to advocate for populations in need everywhere. So I think it's pretty clear that we will continue to do that and to call for access that is needed not only for us but for the other sister UN agencies. Imogen, and then we will close.
Okay, so you didn't want to answer my question about Dr. Tedros's comment. So can I just ask you both your assessment for the next 8 weeks if access remains as negligible as it is now?
I think it's a very important question. What we base our understanding of the situation is, as I said very clearly, we know what diseases exist in Tigray. We know the functionality of the health system. So when you put the health problem there and couple it with the limited ability to treat and prevent, we're deeply worried, and there's enough cause for concern that we're not able to get vaccines into the area, we're not able to get fuel into the area, we're not able to get essential medicines and supplies into the area, and then we know what the problems exist, right? So those are the ingredients that we're deeply concerned about. Those are the worries that children will not be vaccinated. And it's not only about 8 weeks, Imogen, it's about the next 8 years. I mean, we didn't have the chance to even talk about the mental health and the psychosocial needs that are ongoing. When we talk about immunization, it's not about just one shot, a jab in the arm. It's about making sure that there's routine immunization services for these children as they grow up. And I think a number of our colleagues have said many children are being born into this environment. And how much safe space do they have to grow and development? So it's, yes, immediate now to get urgent supplies in, but not just for 8 weeks. We need sustained access, sustained resources to make sure that we can turn a tide in the north. But in addition to that, there are other areas that we're equally concerned about, those areas that I cited in terms of where cholera is. So when you put all this together, the will and the knowledge is there. The access and the resources are needed to help overturn that situation. And so deeply worried.
Thanks. We still have, we have John Zarkostas. And John, I think we will have to wrap up because our colleagues from UNOG need to prepare for the regular press briefing. John?
Yes, good morning. Thank you. I came a bit late, so I've missed a bit of this. I'm sorry. Just one general question. On the WHO website on attacks on healthcare, since this crisis has started, and it's more than 2 years now, it's very sporadic, the documentation on the attacks on health, whether it's facilities or personnel, yet individual reports from the field paint a horrific picture, but we're not getting that from the WHO. Why is that? Even though I understand you have been on the ground and done some field work on that.
I don't know if we have anything specific on northern Ethiopia, but you know, John, very well that we have a system in place to document, to monitor, observe, and report on attacks on health, and there are methods being used to verify these incidents. But maybe Altaf, do you have something specific on this region?
I think just very briefly, the attacks on healthcare program, as defined by the surveillance system you described, is subject to not only ourselves but partners inputting that data into the system. That's part one. And then, as you rightly said, our ability to have firsthand verification and validation of those violations. That is a process that is not streamlined in Ethiopia. We have obviously sent technical expertise down, both at central level, to help increase the capacity, one, of reporting, but two, again, reliance heavily on our own staff to be able to validate and verify that those accounts have happened. And I want to remind people, we go through a triangulation process, and it's not just the physical destruction of the health facility. Any denial, any theft, any blockage of transport of patients into the system also represent an account on attack on healthcare.
Thank you, Dr. Noor. Thank you, Mr. Musani. Thanks to everyone who was with us this morning. You have probably received by now the document with containing the data that has been presented.